Hi, everyone. My name is Brian Knight. I'm the clinical director at the Idaho Crisis and Suicide Hotline. I've been here at the hotline for about a year and a half, started in January of 2024. And we hit the ground running working on this redesign of the Idaho crisis system. So I'm going to talk a little bit today about 988 and the Idaho Crisis and Suicide Hotline and what happens when you contact us. So a little history on the Idaho Crisis and Suicide Hotline. We started back in 2012 and we were kind of a fledgling organization. We started with volunteers and we had limited hours. And over the last 13 years, we've really done a lot of work to professionalize the hotline. We've worked towards 24/7 operations. We became a member of the 988 Suicide and Crisis Lifeline. And now we operate as the crisis care hub for people who are entering the crisis system in Idaho. So we started under the Idaho Behavioral Health Plan doing care traffic control in July of 2024, and we'll talk a little bit about what that entails. But right now, we are staffed fully with trained employees under clinical supervision of myself and another clinician that we have here at the hotline. So the first thing is, how do you contact us? You contact us by calling 988. That's the easiest way. There are several options when you call 988. You can go to the Spanish language line or the Veterans Crisis line. And for the next day or so, you can go to the LGBTQ plus youth and young adult line, but that's discontinuing. And if you get the treat, you can either stay on the line or press 0 to be routed to the Idaho Crisis and Suicide Hotline. If you go to any of these other call centers, you won't get our staff and you won't be able to receive all of the services that we provide, but they're specialized to help individuals in crisis as well. You can also chat with us if you prefer to chat instead of calling and having a conversation. You can chat at idahocrisis.org or you can text us at 988. For individuals who are out of state but want to contact our hotline, maybe because they have a loved one that they're concerned about in Idaho, you can call the Magellan member line at 855-202-0973, extension 9. The way that the routing works is whatever cell phone tower you connect to figures out who you route to. So anybody connecting to a cell phone tower that is located in Idaho who has Verizon, T-Mobile, and AT&T will now route to us. It hasn't always been that way. Over the last year, they've been adjusting these for the major carriers, and over the next year, they should adjust it for the rest of the carriers. So if you have a carrier that's not Verizon, T-Mobile, or AT&T, you might be routed to a different state if your area code is not 208 or 986. So what is a crisis? Some people think that they have to be suicidal or be having a suicidal episode to call us, and that's not true. We work with individuals who have all sorts of different crises. It could be suicide, it could be self-harm, but it could be mental health concerns or substance use and addiction, family or social relationship issues, school issues, financial issues, housing, grief and loss, current events. We get all of these. Sometimes people are dealing with multiple challenges at the same time that are really causing them to have a hard time to cope with whatever it is that's going on in their life. We use the Lifeline Safety Assessment Model. So when you call, this is the model that we use. In fact, every 988 call center should be using this model. All crisis responders across the country are required to do training using this tool. So the first step of the crisis model is to connect and engage with someone. We want to figure out what are their reasons for calling and start to look for reasons to ask about suicide and assess if they've done anything to harm themselves. We want to listen and clarify what are all the contributing factors to their crisis, and then we want to engage with them to collaborate and create a plan that will help them resolve their crisis. And then as we develop that plan, then we can offer a follow-up and then wrap up the call. We have a lot of people call us who are not necessarily in crisis themselves, but they're concerned about somebody else who is in crisis. Especially during the day, this is a very common type of call that we work with. And so we have a third-party triage procedure that we run through where we want to figure out what is happening with the individual you're concerned about. Are there triggers or history of similar crises? What were their outcomes? What worked? What didn't work? And then what sort of solutions are you looking for? Maybe it's a specific service, or maybe it's you want us to contact them. So we'll kind of get an idea of what is it that you're hoping that we might do. Then we'll want to do a full assessment on the what we call the recipient of care. That's the person that you're concerned about, the person who's in crisis. So we'll ask, have they expressed any suicidal thoughts, or have they done anything to harm themselves? Have they expressed that they want to harm anyone else, or do they have a history of harming other people when they're in crisis? And then we'll want to look at, are there any other mental health symptoms, substance use, or medical or neurocognitive issues, or other environmental factors that are affecting the crisis? Then we'll assess the third-party caller's safety. So have you had thoughts of suicide or self-harm? Have you been having thoughts of harming anybody else or harming the person who's in crisis? And we'll want to see, are you at risk for harm from the person who's in crisis, or are there other people who are at risk for harm? Then we'll want to create a plan to keep everyone safe. At that point, we'll start to work toward a plan. How do we want to help the individuals in crisis? Are there coping strategies that you can help them with? If they're going to harm themselves, do they have means? Can we work towards removing access to the means? Do we need to create a plan to keep other people safe? What sort of referrals or resources might be helpful? And then we will want to kind of figure out, do you want us to try to contact the person you're concerned about? Maybe we'll do a mobile response team dispatch, and Sarah and Daren are going to talk about that in a bit. Or maybe they can go to a crisis center or recovery support center, or maybe they need emergency room, psychiatric hospital, or law enforcement emergency intervention. So there's lots of options, and we can kind of talk through the pros and cons of each option and figure out what's appropriate for the crisis. So under this new system that we've been operating for about a year, the Idaho Crisis and Suicide Hotline is dispatching the mobile response teams. So these are individuals who go out and meet with the individual in crisis in person in the community. We have just started the third phase of this rollout, so it's now 24/7, 365 days a year. And we've been doing overnight dispatches for a little over 2 weeks now, and it's becoming more and more common. Every night we're sending mobile response teams out to see people. So if you're calling us and you're looking for a mobile response team, we do have a triage process that we go through. We've got to fill out a dispatch form, and then we send it over to either Benchmark or Community Bridges. And so the things that we're looking for when we want to dispatch a mobile response team is, what's the primary concern? What's the issue that's going on? And then are there any secondary issues or other contributing issues that are impacting the crisis? What is a little bit of demographic information about the individual? Where is the individual? And then we want to know, is there a history of mental health, substance use, or violence? And then we'll look at, are there weapons present, or are there animals present that we should be worried about? We'll encourage individuals who are in crisis to make sure that they put their animals away so that they're not interfering. If it's a third-party caller, we'll want to kind of collaborate with you on whether or not it makes sense to make sure the individual in crisis is aware that we're sending a mobile response team, and whether or not we should try to get consent for that team to show up. So are they aware and willing to engage with the mobile response team? And they don't necessarily have to be, but it's often helpful if they know that someone's coming. But we can send the mobile response team, and they can engage the individual and get that consent themselves if they need to. So There is some thought around, or I've heard some people in the community say that if you call 988, they'll always call the cops. And I know this is a thing that we're constantly worried about and kind of thinking through how do we reduce law enforcement, because that really is one of the main goals of 988 is to reduce the use of law enforcement for people who are having a behavioral health crisis. And so I wanted to share with you a little bit about what the actual outcomes are. We utilize law enforcement less than 1% of the time when we have people call us. So, and the reasons that we do utilize law enforcement is either somebody has taken action to harm themselves either during or before the call and they need medical attention, or they're at imminent risk, which means that they're reporting a desire, intent, and capability to take lethal action toward themselves or another individual. And so we'll utilize law enforcement to go make sure that they're safe. Now, we really want to use our model. So if they might call us at a point where they're reporting desire, intent, and capability to take lethal action, but we use our intervention skills to help them find reasons to live and turn toward safety. And so the big goal would be to utilize less invasive intervention than law enforcement or emergency rooms, really. And so we do refer or dispatch mobile response teams about 6% of the time, and we help people access crisis centers about 3% of the time. So you can see this is our total contacts inbound and outbound on all lines. We started doing crisis services under the new Idaho Behavioral Health Plan in Q3 of 2024. So you'll see a pretty large bump in our contacts during that quarter. And then we've increased to about 7,300 contacts a quarter and leveled off there. So it's been pretty steady for the last year and definitely more busy than it was before the Idaho Behavioral Health Plan. And I mentioned before, there's those other lines. And so you can see for the first half of this year, how many contacts we had that were incoming through 988 as compared to the Veterans Crisis line, the Spanish line, and the LGBTQ plus youth and young adult line. And then here's a map of our contacts by county. The new system where they geo-route the calls based on the location of the cell phone tower has really improved our data here. We used to have a map, but it was not super reliable. It was based on the individual's phone number and not their actual location. So this gives us a lot better information about who is calling from where. And you'll see, kind of as we would expect, the counties with more population are more busy, but there are some smaller counties that do have a fairly decent amount of utilization of the hotline. And here's our mobile response team dispatches by region. So you can see regions 3 and 4 are the most utilized, but we do have dispatches to every region. And I think we have dispatches to most of Idaho's 44 counties. Okay, and I'll turn it over to Sarah and Daren.
Hello, everyone. Thanks so much for having us. My name's Sarah Goddard, and I am the clinical director for Benchmark Human Services, which is one of the 2 mobile response teams awarded the contract for the state of Idaho.
Next slide, Brent. Thanks, Sarah. My name is Daren Fry, Vice President, Regional Operations for Community Bridges Incorporated. We're the other mobile response team contractor in the state of Idaho that Sarah was mentioning. You'll see our vehicles running around with CBI on the side of them. CBI stands for Community Bridges Incorporated. So that's us when you see us roaming around. We're going to talk a little bit more about the regions we run in here in just a little bit. But wanted to, next slide, Brian. Wanted to give just a quick overview of who we are. Besides being very excited to be one of the new crisis providers there in the state of Idaho, CBI is a national behavioral health agency. We have programming that runs there in Idaho, Arizona, Oklahoma, and Washington, D.C. We are an Arizona-based agency, and throughout our continuum of care across the United States, we have every level of care. It's not a lot of which is in Arizona, from psychiatric inpatient hospitals to inpatient crisis chair and crisis inpatient facilities, crisis mobile teams, among other product lines. Like we do big shelter systems, outpatient services, residential. So we are roughly 2,000 employees running in almost coast to coast in the United States. Thank you for the time, and I'll turn it back over to Sarah.
Awesome. And so for Benchmark Human Services, we are also new to Idaho with this rollout of mobile crisis services July of last year. But our company has just celebrated their 65th year, which is really amazing. And a lot of the things that we do in other states, things like crisis respite homes, family preservation services, crisis response, group homes, all sorts of supportive living. The company really started, their hub is in Indiana, where we primarily focused on the intellectual and developmentally delayed population. And so we're excited that about 15 or 16 years ago, we really dove deeper into behavioral health. And so obviously our mobile crisis team is an extension of that. All right, so really what we're hoping, Daren and I are hoping that you guys take away from today's presentation on the mobile response side of things is to really learn what mobile response teams are. So the acronym we use is MRT. We hope that you take away and learn how our mobile teams respond to crisis. We'll talk about some goals of our program. We'll also retouch on defining different types of crisis. And then at the end there, we'll wrap up and really talk about more like what do we do on scene with people when we show up? So types of intervention, how we connect people in the community, and then of course, details about our follow-up process. Awesome. So kind of first and foremost, what is mobile response? So as everyone's mentioned, we're a new crisis response system in Idaho, contracted through Magellan, so both CBI and Benchmark. We're awarded that contract and we now provide regional response across the state. And we are solely dispatched through 988. So really it's that crisis continuum of care, the 3-pillar system, which is someone to call, which is 988, someone to respond, mobile response, and then somewhere to go, which are the crisis centers. And so kind of on this map here, Daren and I will kind of discuss who covers what region. So the blue circles on that left-hand side is Benchmark. So Benchmark is responsible for North Idaho, which is regions 1 and 2. So we respond all the way north to the Canadian border, west to Washington, a bit into Oregon, like the Oregon border, and then as east as Montana. Our regions 1 and 2 team go down all the way through Lewiston. About 45 minutes south of Lewiston is as far as that team will go. They have an office in Coeur d'Alene, and then we also have an office in Boise, and our Southwest team covers regions 3 and 4, while also CBI's help there.
And thank you, Sarah, and the red lines, the red circles are CBI. One of the things that I've heard asked when we've used this map is, well, what happens for everything that's not circled? And I think Sarah did a really nice job of explaining how our teams run. And as also Sarah mentioned too, we only dispatch through the 90-day system, and Brian's team did a wonderful job over there. They look at, who's the closest mobile response team that's available. And there's oftentimes, if it's Benchmark has got the closest, versus CBI, they're going to send the right and the closest and most available team to the person in crisis. So although the map doesn't show, we do cover the whole state. We have our office in Boise, and our teams are running the southeast rural part of the state, actually run out of Pocatello, and they actually dispatch remotely out of Pocatello. Then we cover that whole section, southeast Idaho.
Awesome. So kind of first and foremost, what does it look like for us to respond to crisis? So as mentioned, the individual themselves in crisis or any third-party caller could be family, friends, neighbors, providers, law enforcement, first responders, anyone can call into 988, work with their responders over the phone to determine if a mobile response is appropriate. Everyone dials through 988, and then first responders have a more direct backline number so they can have really quick access to our mobile teams. But once that is determined that a mobile response team is appropriate, again, they use our location geographically to see which team is closest and then go ahead and dispatch us. So our teams have access to kind of a communal system, an internal system that we use that shows us where we're dispatched to, important safety information about the crisis and the caller, a location so we know where we're going, right? We know if our dispatch is 5 minutes down the road or if our dispatch is 3 hours. And so we know kind of how to navigate that right off the bat. And when we are dispatched, people in the community can expect to meet with a team of 2. So for Benchmark specifically, we have what's called an affiliate clinical level staff, which is a bachelor or master's level clinician who responds with a certified peer support specialist. And then I know for CBI, they have a behavioral health technician paired with a peer support specialist. So you will always be getting that team of 2. And again, our 2 responders have kind of unique backgrounds and professional experience that they bring to the table. And then, of course, that peer support has that lived experience where really they're able to connect with someone in a pretty immediate and uncanny way, right? They've been in crisis, they've struggled, and really they're working their recovery. So it's a really beautiful time for them to use what they've learned to instill hope into clients who are struggling. In terms of kind of logistics of the program, we serve individuals across the lifespan, so age is not a disqualifier. And certain types of crises aren't necessarily a disqualifier. So for example, we serve adolescents. I know the youngest we've served, I think, is 4. The oldest is 98, and I'm sure we may see something outside of that at some point. But really, we just want to make sure that the community and the people in need, that their needs are being met. And then, of course, we just have to have a location to meet with someone in crisis, but even that gets just a little bit gray. So if we know we've responded to obviously people's homes, providers' offices, lots of different community locations like your local McDonald's or at a park on a park bench. So as long as we have, somewhat of a location or even like a description of what the person's wearing, we can usually make that work. And then obviously our hours are still on there too. All right, so goals of our program that may be a little bit different than some other community agencies. First and foremost, we want to help de-escalate people's crisis, which can really look different for everyone. We want to be able to instill hope in people, right? Show them that there's something worth living for, that there's something worth them putting in the energy with us, right? So that we can help get them to that next step. Providing different types of support. A lot of times people in crisis share with us that they feel like they have a real lack of supports or don't feel like the supports they have are supporting them in the way that they need. A lot of times people have kind of burnt bridges with their family, their friends, their providers. And so it's a nice opportunity to meet with someone who's really outside of that and has that non-judgmental, really open-minded approach with them. Of course, we want to increase their independence and self-determination. We want to support really what they want to do for themselves. We're not out there to really make decisions for them. And then hopefully we're helping prevent future crises by doing that type of intervention. But one thing that we really focus on is that mobile response team's approach is the least restrictive approach. And so what that means is, what can we do as a mobile response team, for example, to reduce the amount of contact that our individuals have with law enforcement, right? The system that people have been using for years is called 911 in a crisis, when really now we want to be diverting people in mental health crisis to 988 so that they're getting the proper support that they need. And then, of course, we can do co-response if needed, but it's a good option for us to kind of see what we can do with someone before we have to bring law enforcement in. And then the other end of that is reducing emergency room visits and psychiatric admissions whenever possible. So what can we do to community stabilize this person to prevent them being slapped with a hospital bill or going into an inpatient facility when maybe really what they needed was a solid safety plan in the community and being wrapped around with the right services. So a lot of these things help guide the way that we engage with clients in crisis. All right. And then one thing I just wanted to touch on again that goes back to what Brian shared. That's a really important part of our program and how we really developed this is to redefine what it means for people in our community to be in crisis. So that's mental health crisis, that's behavioral health crisis, that's suicidal crisis. But ultimately, everyone that we meet with, their crisis looks a little bit different. So if you are unsure of someone that you're concerned about or your own crisis and whether or not it fits into this, we really encourage everyone just to make that call to 988 and work with those responders to determine if MRT is appropriate for that crisis. Some examples of things that are most common that we've been out on, substance use crisis, obviously people who are experiencing suicidal ideation, and there's a really large portion of active psychosis. So whether that's true psychotic illness or substance induced, we see a lot of people who experience psychotic symptoms. And then another one I think at least that's been common for us is behavioral needs for kiddos, and then like early onset symptoms of dementia for older folks. So just to kind of give an idea of the wide array of types of crises that we respond to.
Thank you, Sarah. So I often get asked, what is actually an intervention? So what can people expect when our teams come out there? And so I kind of want to talk just briefly about the first two bullet points together. So on-site de-escalation and rapport building through a clinician and our peers. So this should also really be happening in tandem. Our teams get extensive training on de-escalation techniques, but I think the most important stuff that our teams get trained on is like how do we approach something from a trauma-informed approach? How do we, what are we doing when we get on site to build rapport with folks and helping people understand exactly what it is we're there to do. We're there to help them. I think oftentimes when I get a chance to talk with our teams, one of the things I often want to remind our team, I think it's sometimes better if our teams would do a little more of this, a little more listening, and not as much talking. Because we need to understand why you've reached out through the crisis continuum in Idaho today, and what is it that our teams can do to assist you find a place of stability. We definitely want to make sure that our teams are non-biased in their approach, but also making sure that it's patient-centered, right? So we want to make sure that every crisis is going to look a little different, and we need to make sure that we're approaching every crisis from a trauma-informed and from a patient-centered individual basis first. Creating a safe environment, our teams will dispatch to wherever Brian's teams at 988 will send us. Most oftentimes it's in somebody's home, or maybe it's in a Walmart parking lot. Often, it's going to be wherever the crisis brings us to. What does creating a safe environment mean? How does that client feel safe at that particular moment in time? What are we going to do to ensure that person feels not just physically safe, but safe to have a conversation with us about, what it is that we can do to assist them with finding the resources they need. And another thing I get asked about quite a bit is, well, how long are these teams there? Well, that's defined by the intervention. That's defined by the person that's in crisis. I can tell you averages, but what I really want to leave today is our team are going to be there as long as the client needs us or the consumer needs us to be there to ensure that they are safe and ensure that they have the resources to continue to be safe and have the resources they need to provide for themselves and their families. I would say an average intervention probably runs somewhere between an hour and a half and two. We've seen interventions that can last, I've seen them last 7 or 8 hours, and I've seen them last as quick as just 15, 20 minutes. But I would say on an average across the board, we're looking at about an hour and a half to 2 hours start to finish of intervention. So what kind of an assessment can people be expecting when our teams get there? Well, as Sarah pointed out earlier, the model and the people that are coming out to see them and what the type of assessment we're going to be doing when we get there Oftentimes we hear word assessment, and when we're talking about mental health, anybody who's ever experienced going to an outpatient clinic for the first time and what that assessment may look like, or if they've been in a hospital setting and what does that assessment look like? Those are very, very extensive assessments that can last, the assessment alone can last an hour, hour and a half. Our teams are trained and have the tools to do what we call a mobile intervention assessment and a risk assessment. So we want to make sure that we're gathering enough information that we can help determine what it is that we can support you with. We also want to make sure that we're using an assessment that helps us determine risk. What is the risk level for the person in crisis, and what is it? What type of resources do we need to use to ensure that person gets the help they need and themselves and the community stays safe. And then also, we always want to make sure we're looking at this from a family and or social support process, right? It's easy to talk when we're talking about kids. Of course, we have to have the guardians involved when it is kids, but how does that look like when it's adults? Brian was talking about what a third party caller is, or just a little bit earlier. Oftentimes, too, we're going to encounter family and social supports while we're doing while we're working, doing the intervention with the person in crisis. I think it's most important to have the social supports and family members involved. They're the ones that are going to be able to help that person long term, be successful. And we're going to talk a little bit here just a minute about safety planning. I think it's super important to have family and social supports involved when we're doing safety planning, because that's that person's team. And I think somebody's only going to be successful with their plan as long as their whole team's involved. Next slide, Brad. So what are some of the things we do, and talk a little bit just about what are some of the things that teams will do when they're there. One of the things that is I think most important to talk about when we're talking about mobile crisis is our teams are trained, and we're coming to the approach the least restrictive possible way to help somebody become stable. One of the things that we're not doing is we're not pulling up there, doing a quick assessment, trying to determine just what hospital we need to find for that person. If and we'll talk about that here in just a few minutes, but in the event that person does need a higher level of care, we can assist with that, but we want to make sure that we're working on this from a least restrictive possible scenario and approach. So we're finding the right resources, but not looking to just try to put somebody in a higher level of care or system into a higher level of care if that's not what's needed. It's also super important we're getting to release some information so we can have a conversation with the resources. We can help connect people to resources, but people have rights, privacy rights. So we want to make sure if we're going to be doing that, we're doing that with the patient's consent. We can help get appointments scheduled with outpatient clinics. We can help folks get reconnected. We can help people get connected to some of the social supports. We can help people get connected to resources as simple as as getting them connected to somebody that can help with the food box, or we can help all the way up to getting appointments set up with an outpatient provider so that person can get all the help they need. I did talk briefly about safety planning. What does that look? Well, it's individualized. It's each person's going to have a unique safety plan. What may be a safety plan for me may look a little bit different if we were working on one with Sarah. We got to make sure that we're coming from a patient-centered approach to that, making sure we're tailoring the safety plan for what works for that person. We also want to work with that person so this is another important place for family and social supports when we're looking to remove or restrict access to lethal means. We do not have just one of the things that I want to make sure I stress, our crisis mobile teams are not there with any ability to remove something forcibly. So if somebody has a weapon, we can work with that person to secure that. But Brian did talk a little bit earlier about I'd say rare, but the times we have to utilize our assistance from law enforcement and our first responder community is to make sure that we can successfully help people lock up guns and lock up knives and lock up medication, but do it because it's their property. How are we going to help that person do that efficiently and make sure that we're ensuring safety? What's a warm handoff to a higher level of care mean? That means it's us helping. Sarah talked a little bit about the continuum of care a little bit ago. It's that place to go, right? So what does that look like? Well, Idaho has a wonderful series of crisis facilities where we can help people get into. There are inpatient psychiatric facilities we can help people get into a bed in one of those. But if, one of the things that we're always going to look at first when our teams get on site and on scene with the consumer is medical safety first. We can't do anything if that person is in some kind of acute medical danger. So if we need be, we can work with 911 system to make sure somebody's getting transferred out quickly and effectively to ensure that they're medically stable before we can start working on some kind of intervention. When we can help with transportation, I must stress that's on a voluntary basis. We do not do anything that's involuntarily. If I take somebody that has not agreed to get in my car, that's called kidnapping, and I can go to jail for that one. But if somebody does agree to the higher level of care, we have vehicles and teams that are trained. Our teams are trained to be able to assist and get them taken from point A to point B to the crisis center or the hospital. But what a warm handoff means is that team member is walking in, making sure that the person that needs the help is getting safely and properly turned over to the care at the facility we're helping people get to. What is not a warm handoff? That's if somebody pulls up in front of a building and points to, there's your hospital, there's the door. Good luck. That's not what we do. That's not a warm handoff. Warm handoffs mean we're going to help that person get handed off to the level of care we're assisting them with. And law enforcement collaboration is needed. In all my years of doing crisis mobile work, one of the things that has really been interesting is that how little we actually have to use law enforcement. How often do we really need law enforcement? I think that really speaks to the training our teams get and how we approach situations. But if there is an event, and Matt O'Brien's already kind of talked about this a little bit, if there's an event where law enforcement is needed to ensure safety for the consumer in crisis, the community, and of course ourselves as well too, then we're going to involve law enforcement. Something else we work pretty closely with, and what I've seen, and this is where I really believe that the crisis or mobile response team system works the best, is the more we're collaborating with law enforcement, the better the system's going to work. Because as all too often we all know, as most of us know, 911 is what's been utilized for a very, very long time when somebody has any kind of a crisis. And what that does is that typically brings law enforcement to your door. And we work with the law enforcement agencies, so if they have somebody that needs a mobile response team and not a police officer on scene, that law enforcement can then work very quickly to get one of our teams out there to assist, so they can actually step out and let our team step in now. Next slide. And then what do we do afterwards? So we talked briefly about the length of intervention time, the average length of intervention time, hour and a half to 2 hours. So what's next after we clear out of there? Well, we want to make sure that we're checking in with folks. So there's a process where our teams will follow up at the 24-hour and the 72-hour mark to ensure that people are still getting the services they need, the services we've assisted with. We want to make sure they're still okay, they're still safe. We want to check back in with them on that safety plan. And if we're doing our safety plan correctly, us checking in with them should be part of the safety plan. We're going to come check back in with them and work to find out if there's any additional resources they may need. What else can we do, or what else can we assist with to ensure that somebody's getting all the resources they need. And then really it also gives us an opportunity, if that person is still in crisis, or it could have been a scenario where they're in a new crisis. We can self-dispatch. It means our team can go back out. And if we do that, we're going to approach that like a brand new intervention every time our teams come out there. We want to make sure that we're providing the services that somebody needs and not just kind of trying to guess at it from the last time we were there. So we would work back through the whole intervention again to establish what it is we can do to assist people with. Next slide. Thank you guys so much for your time today. I want to thank you, Mary, for putting this all together, and my counterparts, Sarah and Brian, for all the wonderful work your agencies are doing. And I'll shut up now. Thank you.
So now we have time for question and answer, and we do have some questions in the chat, and I can read those out if you'd like me to.
Yeah, that works. Why don't you read it and then we'll.
Okay. And is it okay if someone has a question, if they turn on raise their hand and turn on their audio, everybody? So I think that would be great. All right. So the first question is, will data be considered at some point in the future from other sources, such as the crisis hotline in Blaine County, which is likely why the numbers are reflected so differently for Blaine County?
Yeah, I can take that. So to talk a little bit about where this data comes from, can you all see my screen again?
Yes.
Okay. So when people call 988 and it's routed to us, the National Suicide and Crisis Lifeline tracks that data. And so then we can pull that data and see who's calling from where. So if an individual is calling another line that's not 988, like a crisis line at a outpatient behavioral health facility or a crisis line that a community has set up, it's not being routed through 988, and therefore we won't be able to get that data through these sort of reports. So I think it will have an impact. I know there are some places that are really encouraging the use of the local line. Um, and that's okay. We don't really want to fight against that, but we won't have good data about what the utilization looks like for those individuals.
Okay. Um, Next question. Can 911 dispatchers dispatch MRT directly, or does the request have to come from the first responder?
So yeah, 911 dispatchers, if they feel like a mobile response team might be a good approach, can contact us at 988. And I think these slides will be available and my email is on that. So if we actually have a direct line for first responders and law enforcement, and dispatchers can utilize that number as well. That goes directly to us, and you can skip the phone tree routing system. And so then you can contact us and then we can let you know, hey, this is the team we have available. This is how long they'll be. And then we coordinate that response as we do the dispatch. Yep, we don't have to have somebody who directly knows, like a friend or family member, request the dispatch. It can be anybody who's requesting it. And we do law enforcement dispatches, and we work with people who are therapists or counselors or medical personnel who are requesting these dispatches. So it really could be anybody.
Great. I was jumping back and forth for a second there, sorry. At one point, the next question is, how long does it take for the mobile response team to be dispatched to the crisis?
I can take that one. I'm wondering if that one's more related to like once we get dispatched, how long does it take to get to the crisis? Because I think on the 988 side, obviously, it just depends how long it takes to gather information in order to dispatch us. But once our teams are dispatched, of course, then we have an idea of how long it's going to take us to get to the location. Which, as you could see by our map, there are teams in one spot that cover a pretty large geographic area. So obviously Eastern Idaho, their team out there, and our North Idaho team in Coeur d'Alene cover a pretty large portion of the state of Idaho. And so, yes, there are times that we'll get dispatched and it will be local, and there's times where we'll get dispatched and it'll be pretty far away. We do have response times set up contractually through Magellan that for an urban response, we have 60 minutes to get to that location. For a rural area, we have 120 minutes to respond. And for those really remote areas, we have 180 minutes to respond to that crisis. Based on Magellan's previous data that we've been well under those times in each of those categories. But something that we do kind of in each of our programs, if we get a dispatch and it looks like it's going to take us a while to get there, we're communicating that directly with the third party. So if it was a provider, family, law enforcement, we're going to call that person as long as we have their info from 988 to let them know how long it's going to take us and discuss what we can do to hopefully help that time feel a lot less. We can also reach out to the individual themselves, especially if they called in requesting a crisis response. And we can start building that rapport and doing some of our assessment just through, kind of our gathering information and conversation with that person on the phone. So again, we have some strategies in place to hopefully make that response time not feel as long for those locations that are, just pushed out a lot further than the local calls are.
Thanks, Sarah. At one point, there were regional phone numbers to call to speak with the mobile crisis unit. Is it best to go through 988 now, or are there still regional phone numbers?
Yeah, I can take that one. So before July 1st of 2024, there were mobile crisis units for each region. And those, each of the 7 regions, the units operated a little bit differently. There wasn't great consistency. I know in Region 4, they had longer hours than a lot of the other region and were available more often. And some of them did a lot more of a response in person. Some of them did more telephonic response and less in person. And so as we were setting up this new crisis care system, the state worked to close some of those mobile crisis units or kind of change what their goals are. And so a lot of the people who were working on the mobile crisis units now are focusing more on designated exams. And they're not doing crisis response. So all of the mobile crisis response in the state of Idaho is now transitioned to these mobile response teams. So if anybody's wanting a mobile crisis response, this is the process that you'd go through to get that. I think you still can call those different regions, but they're going to be focused more on, I think, designated exams, and they often refer people to us. Sometimes when people call there, they'll transfer them to us, and they'll get 988 anyway.
Thanks, Brian. Amanda, you have a question? You can unmute.
Yeah, hi. I'm just curious about what you guys are finding as far as like homelessness and housing crisis goes. Do you get any calls like that? Is that a need? Is it, I'm just curious about that.
Great, cool.
Sarah, you want to take that? Or Daren?
You want to take that one, Brian?
I can answer it. We do.
Okay, Sarah, go ahead.
The answer is yes, that comes up. I don't know if it's always identified to 988 as, the primary concern. Sometimes it is primary, whether they're at risk of homelessness, already experiencing it, maybe they've just gotten eviction notice, maybe parents are trying to evict, their adult child. There's kind of all sorts of things we have come across. And then sometimes that's not maybe a primary concern, but is something that ends up coming out through our assessment with the person as a stressor or as a concern for them. And so, yeah, that's one of the things that we do our best to find out what local resources are available to them. What can we get them on a housing list? Can we have reached out to landlords on behalf of people who maybe are, behind on rent due to their mental health crisis. So sometimes we're able to do additional advocacy in that arena. But yes, that is definitely something that we see, and we're constantly trying to learn what new, community resources are available to help the people that we meet with. And then on the flip side, sometimes there's just not a whole lot out there depending on the area that they live in, which is just a reality. But what can we do to still support that person, connect them with what we can find, is just a really important piece of that process.
But we would always want everybody to think this way. The crisis is determined by the person who's calling us. It's whatever is a crisis to them, and that's how.
Thank you for that. We'll do one more question and then we'll wrap up. But I want everyone to know that we're keeping track of all the questions and I will send them to our presenters and get answers for them. And in a few days, we can get the answers back to you. I'll send an email with the answers to the questions that were not answered during the webinar, okay? Let's see here. It was stated that an individual has to consent to be transported if a higher level of care is needed, such as being taken to an ER or a crisis center. What if the individual is a minor child who does not want to go but is in need of the higher level of care and meets medical necessity for that level of care and cannot be de-escalated safely for the family to take them, and the family has given consent for the transport of the child despite the youth still not wanting the transport?
That's a great question. We have run into that. The good news is that we don't run into that terribly frequently, but it has happened. And again, it goes back to our process being voluntary. I know that can feel a little bit gray when, guardians and parents are involved. But especially with transportation, we cannot and we would not, force anyone into our vehicle. So sometimes parents will say, they're refusing to go with me, but you need to take them. And I say, well, if they're not going to get in our car with us, you know what I mean? That, there really is a limitation on what we can do. Part of that is not wanting to, bring on additional trauma to them either by forcing them into something like that. And then we have to revisit really what our options are. So depending on the need, is law enforcement an appropriate option in this case? Can we do additional safety planning for the evening and try to, come back out the next day and reassess if the adolescent is more willing? Is there a way to make transportation safer for the parents? But yeah, that does get a little bit sticky, and some hard conversations, with parents about we can't force them into our car if they're not willing to go. And we don't want to create an additional, danger or risk to that person of them potentially then wanting to jump out of the car while we're on the way transporting them. So yeah, some additional considerations, but we do our best to kind of plan B or plan C when we run into that type of issue. Usually parents just end up involving law enforcement because they are pretty set on, wanting their kiddo inpatient.
Thank you, Sarah.
Yeah. Can I just add one thing real quick to that?
Oh, sorry.
I know we're at our time. Just one thing to add to that is sometimes we actually see the opposite though. But we'll go out and we'll meet with adolescents who are willing to go. They're just not willing to be transported by family. Maybe family's a stressor. And so as long as we can get consent from that parent, we can still transport them by themselves and then just have the family meet us at, the location. And we've also had times where we've transported parents and their children or kid. Due to other transportation issues. So it's kind of a combination of things that we do when it comes to transporting kids.
Well, thank you so much, Brian, Sarah, and Daren. Wow, tons of information in this presentation and lots of wonderful questions. As I mentioned, I'll make sure that our presenters get the rest of the questions that we didn't have time to answer, and we'll get those answers out to you. I'm going to send an email in the next hour or so with the survey link and the links from the session and the things that were put in the chat. And I know that Eden already put the survey link in the chat. Go ahead and put it back up there, Eden, if you don't mind. And if you have any other questions, direct them to the Empower Idaho email. And if you can put that up there too, Eden, that'd be great. And the slides and the recording will be available on our website in a couple of days. And I want to thank you all for attending. I can see the survey link is in the chat there, so you can click on it and finish it up. But we appreciate you all coming, and thanks again, Brian, Sarah, and Daren. Great presentation.
Thanks so much.
You all.
Have a wonderful rest of your day, everybody. And thank you, Fran, for your interpreting in ASL. Bye.
Bye all.